Assalamu alaikum. I am Dr. Syeda Farzana Yesmin, Associate Professor Gynae Obst, Khulna Akij Medical College. Today we will discuss about some written questions, also some viva questions. These are related with hysterectomy. At first we should know about Vardim cystectomy, what comprises Vardim's hysterectomy, what are the complications of Vardim's hysterectomy, what are the indications of Vardim's hysterectomy. First we should know the spelling of Vardim's hysterectomy. Some examiners choice to know about the spelling of the Vardim's hysterectomy, and the spelling is Wertheims, Vardim's hysterectomy. And what are the indications of Vardim's hysterectomy? Carcinoma of the cervix up to stage 2A, carcinoma corporis 8 cervicis. And Vardim's hysterectomy comprises of total abdominal hysterectomy with bilateral salpingo-oophorectomy with removal of the parametrial tissue, removal of the upper 2/3 of the vagina, also removal of the pelvic lymph nodes. Pelvic lymph nodes which are removed includes internal iliac obturator, external iliac, sometimes common iliac lymph nodes. So, Vardim's hysterectomy comprises total abdominal hysterectomy with bilateral salpingo-oophorectomy, removal of the parametrial tissue, removal of the upper 2/3 of the vagina, and also removal of the pelvic lymph nodes. What are the complications which may occur during Vardim's hysterectomy? What are the complications which may occur in Vardim's hysterectomy? The complications includes immediate complications and late complications. Immediate complications are hemorrhage, hematoma, shock, injury to the adjacent structures which includes bladder, ureter, intestine, large vessels, etc. And other complications are abdominal distension, paralytic ileus, peritonitis, sepsis. What are the late complications? Late complications of Vardim's hysterectomy. Late complications includes bladder atony, ureteric fistula, lymphocyst formation, and dyspareunia. Bladder atony, late complications of Vardim's hysterectomy. Bladder atony, ureteric fistula, lymphocyst formation, dyspareunia. We at least should know about these in case of Vardim's hysterectomy. What are the roots of hysterectomy? A viva question. What are the roots of hysterectomy? The roots are abdominal, vaginal, and laparoscopic. Without any incision, laparoscopic. So, three roots. There are three roots of hysterectomy: abdominal, vaginal, and laparoscopic. What are the types of laparoscopic hysterectomy? Laparoscopic hysterectomy includes only laparoscopic hysterectomy, laparoscopic assisted vaginal hysterectomy, and laparoscopic supracervical hysterectomy. What are the risks of subtotal hysterectomy? We know subtotal hysterectomy done as emergency peripartum hysterectomy, usually done in obstetric cases and also done in some gynecological cases. Subtotal hysterectomy. What are the risks of subtotal hysterectomy? if we not remove the cervix, there is chance of cervical pathology in future. These pathology includes cervical polyp, cervicitis, cervical ectropion, cervical erosion, even stump carcinoma. So, we prefer surgery during emergency peripartum hysterectomy. We prefer total abdominal hysterectomy nowadays. And what are the sites of possible injury to the bladder while performing abdominal hysterectomy? So, another viva question is what are the sites of possible injury to the bladder while performing abdominal hysterectomy? First, during opening of the parietal peritoneum. If we not check whether gut is held within the peritoneum, then great risk. So, there is chance of injury while opening the parietal peritoneum during abdominal hysterectomy. Also during opening of uterovesical fold of peritoneum, when opening the anterior vaginal wall at the vault of the vagina, during opening of anterior vaginal wall, also during closure of the vault, also during peritonization of the vaginal vault. So, during closure or suture of vaginal vault, during peritonization of vaginal vault and suturing of the angles of the vault, there is chance of injury to the bladder. So, mainly bladder injury. Bladder injury may occur during opening of the parietal peritoneum, during opening of the uterovesical fold of peritoneum, during opening of the vaginal wall, during suturing of the vaginal vault, peritonization of the vaginal vault, and also suturing of the angles of the vault of the vagina. What are the common sites of ureteric injury? Where ureteric injury may occur at the level of the pelvic first of all at the level of the pelvic brim, beneath the infundibulopelvic ligament, at the level of the pelvic brim beneath the infundibulopelvic ligament first, then lateral to the cervix where the uterine artery crosses the ureter, lateral to the cervix, lateral to the vagina where ureter opens into the bladder. Then during peritonization of the pelvis, chance of ureteric injury. Also during retropubic urethropexy, vault suspension, retropubic urethropexy operation, and during caesarean section, if there is any lateral extension of the uterine incision, then there is chance of ureteric injury. Also during suturing of the lateral extension, there is chance of ureteric injury. Ureteric injury usually occurs in the left side and also in the lower third of the maximum, in maximum cases, lower third of the ureter is affected, lower third of the ureter in the left side usually. What are the risk factors? What are the risk factors for urinary tract injuries in obstetric and gynecologic practice? What are the risk factors for ureteric injury during gynecologic and obstetric practice? Some conditions are directly or indirectly distort the anatomy of the pelvic structures and which predispose to injury of the urinary tract. Some conditions that directly or indirectly distort the anatomy of the pelvic tissues and predispose to injury of the urinary tract. Obstetric cases includes repeat caesarean section or previous caesarean section, emergency peripartum hysterectomy, placenta accreta, obstructed labor. And in gynecologic cases, this type of injury may occur in case of adhesiolysis of extensive pelvic endometriosis, chronic pelvic infection and cervical or broad ligament fibroid, and oophorectomy due to ovarian cyst in previous total abdominal hysterectomy. Oophorectomy after previous total abdominal hysterectomy. Also, injury to the urinary tract may occur in case of another gynecologic conditions are prolapse, prior pelvic surgery, in such cases large pelvic mass, prior radiotherapy and prolapse. In such cases also injury may occur. What precautions should be taken before abdominal hysterectomy to prevent any injury to the urinary tract? First of all, we should have proper knowledge of anatomy of the pelvic structures. Anticipating the distorted anatomy of the pelvic organs before clamping. Anticipating the distorted anatomy of the urinary tract in clamping, especially in cases of broad ligament fibroid, cervical fibroid, endometriosis, pelvic inflammatory disease, anticipating the distorted anatomy of the urinary tract. Continuous bladder drainage during operation. Opening of the peritoneal cavity, opening of the peritoneum in the upper 1/3, in the upper portion, not to proceed further down beyond the bleeding capillaries at the lower end of the peritoneal incision, not to proceed beyond the lower end of the peritoneum, not beyond the bleeding capillaries. And bladder should be mobilized. When bladder is separated from the interior vaginal wall, bladder should be mobilized gently with gentle hand. And during careful suturing of the vaginal vault before clamping of the uterine vessels, Mackendorf's ligaments and the infundibulopelvic ligaments. Our clamp should be as possible close to the lateral wall of the uterus, close to the uterus, and bladder should be retracted properly and gently with a retractor. How will we manage if bladder is injured during operation, or what should we do when there is accidental injury to the bladder? We should suture the bladder in 2 layers with atraumatic chromic catgut 0 or 20 or 30 Vicryl. First layer usually given interrupted suture and second layer continuous suture, then continuous bladder drainage for 2 to 3 weeks should be maintained. How will we manage if ureteric injury occurs during operation where urologist is not available? We should know about the repair, end-to-end repair of ureter, and also implantation of the ureter into the bladder or percutaneous ureterostomy. We can call urologist if available. What are the risks of bowel injury during abdominal? When there is risk of injury, bowel injury during abdominal hysterectomy, when bowel injury may occur. Bowel injury is rare, but it may occur when opening of the peritoneum. Any loop of bowel may be held within the artery. So, we should feel first the peritoneum, then incised. Also, bowel injury may occur in case of extensive pelvic endometriosis, chronic pelvic inflammatory disease, also carcinoma of the ovary, advanced malignant ovarian tumor, and in such cases there is risk of injury to the bowel. Injury may occur in the small bowel or in large bowel. In case a small bowel injury can be repaired in 2 layers, Ryle's tube introduced postoperatively for NG suction, and parenteral nutrition should be maintained for at least 4 days. And in case of large bowel injury, it is difficult. If the bowel is not prepared properly before operation, then after repair of the large gut, pelvic colostomy can be done, and these pelvic colostomy should be reversed after 6 weeks. And if bowel is prepared properly before any hysterectomy, then colostomy may not be required. So, our today's discussion is over. We should know about vaginal hysterectomy in next class.